Okay, so Yanxun is a faculty member, assistant professor at the Department of Johns Hopkins University. Her research interests lie in the developing Bayes theory and methods for a broad range of statistical problems such as high-dimensional data analysis and non-parametric problems. She also develops new Bayesian methods for various applications, including electronic health records, dynamic treatment regimes, cancer genomics, early detection of Alzheimer's disease, and mental health in people with HIV. Her talk today is on inferring combination effects of antiretroviral therapy on mental health in people with HIV. So please welcome Yanxun, and all of us except the speaker will turn off our microphone and video to help with the presentation.
Okay, so welcome everyone. So thanks, Vashis, for your nice introduction, and also thanks Fernando for his invitation, although he cannot be here today. So today I will talk about one of my methodological work on developing the Bayesian nonparametric methods for mental health in people with HIV. So first, I would like to thank my collaborator on this project. So it's a joint work with my PhD student Wei from Hopkins, and also Professor Leah Rubin at medical school at Hopkins, and also Dr. Yang from Texas A&M, and Amanda Spence from Georgetown University. And also I would like to thank all the PIs in this cohort study, and they contribute the data to this study and also the funding source. Okay, so as we all know, the virus is an infectious agent that replicates only inside the living cells. It could cause epidemic. So for example, H1N1, SARS, or MERS, and more recently, COVID-19. We're already in this pandemic. Until yesterday, the total number of confirmed cases in the whole world has exceeded 35 million, and the total death toll has reached more than 1 million. So its burden on public health and economy is enormous. Therefore, studying the vaccines and treatments is critical to control these infectious diseases. So in this project, I will focus on HIV, but the methods can be applied to other disease areas. So I will discuss its extension to the COVID-19 research at the end. So HIV stands for human immunodeficiency virus. So this is a virus that attacks human immune cells, such as CD4 T cell. So there's a pathway on how the virus attacks human cells. It first binds to the host cell and then enter. After entering the host cell, the virus RNA is reverse transcribed to DNA, then integrate into the host DNA. After that, the DNA will be transcribed to to create more viral RNAs and proteins affecting mouse cells. So luckily for us, there's already the antiretroviral therapy to treat HIV. So there are more than 30 FDA approved drugs, and different types of the drugs target different steps through this infection pathway. So for example, there's one type of drugs called nucleoside reverse transcriptase inhibitors, NRTIs, so which can block the second step here. It's as an HIV enzyme at this step. So here is a list of commonly used drugs for each drug class. So in general, we have 5 major drug classes. So NRTI we just introduced. So there are 4 other drug types like NRTI. It's non-nucleoside reverse transcriptase inhibitor. It binds to and blocks the HIV reverse transcriptase this step. And also the EI is entry inhibitors. It can block the virus ability to enter the body's CD4 cell. And also PI and I is integrase inhibitor. Okay, so interestingly, there are recently 2 PI drugs. So ritonavir and lopinavir, they are currently used to treat COVID-19 in some clinical trials because they have similar mechanisms. Okay, so in 1980s and early 1990s, the clinicians usually prescribed 1 or 2 drugs for patients called monotherapy or combination therapy. So as different drug classes, these NRTI, EI, and I, they target different steps of the HIV transformation. So since 1995, researchers found out that using a combination of at least 3 drugs from different drug classes called HART, it can be very effective. So nowadays, FDA already recommended using HART. So that's a combination of at least more than 3 drugs for all subjects with HIV. Okay, so due to the huge success of HART, the mortality rate for HIV or AIDS related death has dropped significantly, especially in developed countries. So therefore, the HIV now becoming more like a chronic disease. So the focus of treating HIV has been shifted from reducing the mortality rate to caring for the long-term life quality of people living with HIV, including mental health and also HIV-related comorbidities such as certain lung and kidney diseases. So for example, previous research found out that there's a high prevalence of mental health issues in people with HIV compared to people without HIV. So for example, in the data set HCSUS, about 36 of people with HIV has major depression. As there are many potential reasons that could cause depression. And one question we want to ask in this project is the ART, that's antiretroviral therapy, is this drugs a risk factor for depression in people with HIV? So for the ART, it could help the depression through the viral suppression, but it can also make the depression situation worse because the ART itself might have the neuropsychiatric side effects. So before we understand the drug effects on depression, let us first see how to measure depression. In general, the depression is measured by a survey. So for example, CESD, so this survey was developed at Hopkins many years ago. This survey has 20 questions, and each question score is from 0 to 3. And 0 means least severe, and 3 means most severe. So for example, like I felt fearful. So if 0 means you do not feel fearful at all, and 3 means the worst situation. And people usually use the sum score to represent a person's depression. So the sum score is from 0 to 60 because we have 20 questions and each one is from 0 to 3. And clinically, if the sum score is above 16, and then we will see this person is depressed. However, one natural question to ask is sum score enough? So many researchers have already studied the depression, and they found out the depression items actually are usually divided into 4 categories. So somatic symptom, negative affect, positive affect, and the interpersonal symptom. So here I use different colors to represent different types of symptom. And these different types of symptoms represent different perspectives of depression symptoms. And so the depression itself is a heterogeneous disease. So assume we have 2 people. If they have the exact the same sum score, but they might have very different symptoms. So they might not share any common symptom. And for different symptoms, we might need different treatments or different drugs to manage. Okay, so now we have already known the ART could be a risk factor for depression in people with HIV. And also depression itself is a heterogeneous disease. However, little is known about the ART effects on depression. So people guess the ART related efficacy or their mechanisms of action or their side effects could be different for different biological sexes, ages, or BMIs, but there's no systematic study on these drug effects on the mental health. So the primary aim of this study is to examine the ART drug combination effects on heterogeneous depressive symptoms among the heterogeneous population with HIV through the electronic medical record data. And here we have the data called WISE. It's Women's Interagency HIV Study. So in this study, we have people's depression level evaluation, and we have their basic and behavior information like demographics, and also we have their clinical factor information such as RNA viral load and the CD4 count, and also if they have hypertension or other clinical information. And also we have their drug use information. So our goal is to integrate all this information to learn the drug combination effect, because we know everyone now usually takes more than 3 types of the drugs. So to analyze such kind of data, there are many challenges. So the first challenge is this electronic medical record data is longitudinal. So here I plot one person's visits. So in general, the subjects, they really visit the clinic every half year. And here the upper panel figure, the x-axis is the calendar dates this person visited the clinic, and the y-axis is the number of drugs used, and different colors represent the different classes. Remember I said we have 5 major classes of drugs. And the below figure shows this person's depression score for these 4 different categories along the time. So the first challenge is how to deal with these longitudinal visits and also the longitudinal data of the medication use and also their depression responses. And the second challenge is irregular visits. So different subjects, they visited their clinic in different times. So in this data set, the number of visits varies from 1 to 44 for patients. And also the data set is heterogeneous. So here I have 2 patients, and we see the individual 1 and 2. So first, we know they have very different number of visits, right? So individual 2 has much more visits compared to the individual 1. And also the individual 2 uses more drugs and even, a more combination of different types of drugs compared to individual 1. And also if you see the depression situation, this person seems more depressed compared to individual 1. So that's one challenge is about heterogeneous population. So besides these data challenges, we also have many challenges related to the drug combinations. So first, it's high dimensionality issue, because with more than 20 ART drugs on the market, there are nearly 500,000 possible drug combinations. So think about it, you can get drug from like 3 or 4 different categories, then you have many possible choices. So here we calculate it's about 500,000 possible drug combinations. And also the data is unbalancedness. So in the data set, some ART combinations are very frequently used, but others are rarely used. So for example, here a combination is D4T plus LAM plus NFV, so that's 2 NRTIs and 1 PI. So this drug combination was recorded almost 1,000 times in the Ys, but a similar ART regimen, so it's still 2 same NRTIs, but with the other drug was only recorded 12 times. So the data is highly unbalanced for different drug combinations. And also the data is sparse. So it means among these almost 500,000 possible drug combinations, only a tiny proportion were observed in the Ys. So it's about a little bit over 1,000 drug combinations were observed. So how can we estimate the drug effects due to this sparseness of the data? I think the one naive solution is you can fit linear regression. But this way you can do for like the drug combination that were observed so many times, you can just use linear regression for those drug regimens. However, for the drug regimens, they are rarely used or even never used. You cannot use these kind of methods. So it cannot be used for extrapolation. And also we want to take into account this drug history dependent property. So that means for one current drug combination, the effect of the current regimen is very likely to depend on the prior ART regimen use, right? So for example, if you keep using certain drug combination for a long time, and then this drug combination might have a high toxicity compared to another drug combination that's only used for few visits. That means a shorter time period. So our methods wants to incorporate the drug history. So now I summarize all these challenges regarding the data and also the drug combinations. So how can we solve this problem? Now let's move to the methodology part. So before I introduce the detailed method, here is the notations. So we have the YIJQ denotes the score of depression atom Q. So we have 4 depression categories. So and for individual I at visit J. So here I is from 1 to N, J is from 1 to JI. That means different subjects have different number of visits, and Q is from 1 to Q. And also we use ZIJ to denote the ART regimen used by individual I at visit J. So for example, if ZIJ equals to these 3 drugs, D4T plus LM plus NFV, if the individual I takes a combination of these drugs at visit J. So we can see here, the parameter ZIJ actually is very different from the regular random variables we usually use for the model, right? It's a drug combination. So we'll talk about how to deal with these kind of variables in the model. And also Xij is an S-dimensional vector, including intercept, time invariant covariance, and also time varying covariance. Okay, so here is an overview of the model. So we decompose the modeling of Yij is a vector into 3 parts. The first part is non-ART effect. And this might include demographic, behavior, and clinical factors. So this part, we just use a simple linear regression. And the second part is ART combination effect. So this is the key of our model. There are 2 designed properties for the ART combination effect. So first, we want different drug combinations to share certain information, right? Because only a very small proportion of drug combinations were observed in the data. If we want to estimate any arbitrary drug combination effect, then we want the different drug combinations, they can share certain information. And also, we also want to reduce the high dimensionality issue because the possible dimension of drug combination is huge. So to achieve these 2 goals, we decide to use a kernel method. So here we first introduce ZD, we call the representative ART regimen, we'll introduce later, which kind of lacks the knots in splines. And also for each regimen, we define a similarity kappa. So that means for any possible drug combinations, as long as we select a bunch of representative ART regimens, and then we define the similarity between this drug combination and these representative ART regimens, and then we can estimate their effect. So therefore, we have 2 questions here. First, how to select these representative drug regimens, and also how to define the similarity function. So we will talk about these 2 points later. And lastly, we have omega ij to take into account the depression dependency, because we have 4 different categories of depressions, but they could be correlated. And also the epsilon ij is independent noise. So here we also just use simple models. The omega ij assume it's Markov normal distribution, and the epsilon ij is a diagonal. It's also the Markov normal distribution, but with diagonal as sigma epsilon square. Okay, so now first let's talk about how to define this ART regimen similarity. Okay, for the ART regimen similarity, we think about, if 2 subjects use similar drug combinations, then their effect should be similar, right? So a naive solution is you can use linear kernel. So the linear kernel will be you compute the similarity between regimens based on the proportion of common drugs that 2 regimens share. So for example, if you have the D4T plus LM plus NFV, so that's 2 NRTS plus PI. And if you think about these 3 regimens, they all use the D4T and the LAM, these 2 NRTS. I just use a different 3rd drug. So the linear kernel will assign the same similarity for the pairwise relationship of these 3 drugs, right? But however, it didn't take into account. So for example, here you have 2 PIs, and here is the EFV is NRTI. So it might be possible for the 2 NRTIs and the 1 PI, they will be more similar compared to their relationship between those 2 drug combinations and this one. And also if you consider another situation, so let's say we have another drug combination. It's also 2 NRTIs and 1 PI, but they use exactly different drugs. if we use a linear kernel and we just compute the proportion of common drugs these two regimens share, we will assign 0 similarity to these two drug regimens, right? But however, NRTIs, they have similar mechanism, and the PI also have similar mechanisms. So even they use different drugs, but because they belong to the same category, we might also want to define certain similarity between these two drug regimens. So in this work, we used a method called subsymmetry kernel method to define the similarity. So subsymmetry kernel was firstly proposed in natural language processing. And the idea is the subsymmetry kernel calculates the similarity between the regimens across all levels of the tree representation of the ART. So here is illustration of our method. So the first level of the tree is ART. So everyone is the same because they are all using the antiretroviral drugs. And the second level represents what drug classes are used. So for example, here is ARTI and NRTI, here's NRTI and the PI. So the second level denotes what kind of drug classes they are used. And then the third level represents the number of drugs in each category. So here we have 2 NRTI drugs and 1 NRTI. Here we have 2 NRTIs and 1 PI. And here we have 2 NRTIs and 2 PIs. And then the last level denotes the exact drug used in each drug class. Okay, so and then we have the formula for the similarity between two traits here. So assume we have two traits, TA and TB. So we calculate their similarity based on the sum of all their nodes. Okay, and here is the definition. I just list the process of how to calculate the similarity between two traits. So first, if RA and RB are terminal nodes, then their rho equals 0. And also if the RA and RB, if they have different size of children nodes, and also their similarity is 0. But if they have the same non-empty set of children nodes, and then we define this as the eta, as a hyperparameter, and the product of the number of their children nodes, and then 1 plus rho, there's a similarity between these children nodes. So it's kind of like we use these iterative methods to define the similarity between two traits using the subsymmetry kernel. And here the D is the similarity matrix we calculate from the subsymmetry kernel. So we can see the diagonal is their the self-similarity. So because the regimen A and B, both of them, they have 3 drugs, so we can see their self-similarity is the same. But for the C, there's this regimen, the self-similarity is higher compared to A and B because we assume, if you use 4 drugs, and for the 4 drugs, their similarity should be harder, like it's harder to use exactly the same 4 drugs compared to the 3 drugs. So here you see we also take into account that. And then we can also have like A and B, they're more similar compared to A and C. And this similarity matrix also takes into account that. Okay, so that's how we define the ART regimen similarity. So now let's go back to the overview of the model. So we already have the subsymmetry kernel to define the similarity. But still, even we reduce the dimension of the drug combination space, from this 500,000 possible combinations to these D representative drug regimens. However, we still don't have control for the multicollinearity. So in this work, we use a PCA to control for the multilinearity and also reduce dimensionality, because this multilinearity is okay for the fitting of the mental health, like the YIG, the responses here, but it could cause the problems in the posterior sampling stability and the convergence. So we apply the PCA for these drug similarities. It's kind of like the matrix in the end, but you only need to do this once, because if you already calculate the similarity, and then you just need to do the PCA once. And also if you do the PCA here, the interpretation of the parameters will be better compared to use the original representative drugs. Okay, so now we talk about the similarity and how to define the similarity between the drug regimens and also reduce the dimension. And the next thing is how to take into account the heterogeneous population. And one naive solution is, we have this BNP community, we can use the division process prime, right? So if you write down all our parameters as here as theta I, it's a beta I in the non-ART effect, and all these gammas in the subsymmetry kernel, and then we can cluster the individuals with similarity drag effects, and we can use the division process prime. So I think I can skip what is division process for this audience. Yeah, but however, if we use the DP to give the prime on the theta I, we can take into account this heterogeneous population, but there's another challenge. So how to account for the drug history? So we know the effect of the current regimen, it might depend on the drug history, but for the DP prime, we assume each individual they are independent, right? So here we adopt the idea from David Dahl's work is the distance-dependent Chinese random process prime. So because the distance-dependent Chinese random process prime, they assume the co-classing probability depend on certain distance. So here S is a treatment history similarity. So it depends on certain distance for the treatment history similarity. And here is the details of the DDCRP. So for the DDCRP, when we write down the marginal probability is similar to the DP, but they have this additional term. So this additional term defines some certain similarity between different individuals. So here, if we use the sigma T and sigma S to denote for two subjects treatment history, and then we can have this clustering probability dependent on those people's treatment history. So using the DDCRP, we can achieve these two goals together. So first, we can cluster the individuals by assuming if two individuals belong to the same cluster, then they share the same parameters. And also, we can take into account the drug history similarity. And now the only question left is how to define the similarity among the treatment histories, right? So we have already used the subsymmetry kernel to define the similarity between two treatment regimens, but we haven't talked about how to calculate the individual's treatment history similarity. And here actually is very straightforward. If we already know the subsymmetry kernel for the similarity between regimens, we just extend the similarity function for two regimens to sequences of drug regimens. So here, assume this person had 3 visits, and the first visits use the default T plus RTV, and the second use these 3 drugs, and third use these 3 drugs. And then we add additional layer for this tree representation. So we have regimen 1, 2, and 3. And then now if you have another person's sequence of treatments, and we can use exactly the same formula to calculate the similarity between these 2 sequences of treatment regimens. So it's very straightforward extension from the single treatment regimens to sequences of treatment regimens using subsymmetry kernel. Okay, so here is a summary of our model. So we decompose our model to 3 parts: non-ART effect, ART combination drug effect, and also the multivariate normal distribution to take into account the correlation between different depression atoms and the noise. And for the ART drug combination effect, we have this kernel method, and we use a subsymmetry kernel to denote the ART regimen similarity. And for the prime, we use the DDCRP prime, so we can take into account the heterogeneous population as well as the treatment history similarity. So here is the whole the summary of the model. And for the posterior inference, we use skip sampler and metropolis histine sampler. So I can just skip all the details for the MSS derivations. So now let's talk about the simulation study. So in the simulation setup, we will assume there are 200 individuals, and the individuals' treatment histories were randomly sampled from the real data set, from the WISE data set without replacement. So resulting in the number of visits per individual to range from 2 to 38. And the classing membership was randomly sampled from the DDCRP prime. And we have 3 clusters, and the number of individuals in each cluster is 67, 61, and 72 respectively. And also we assume we have 3 depression atoms and 3 covariates. Okay, and also here we select 56 representative ART drugs if a regimen has been used in more than 10 visits among all the 200 individuals. So in general, if one ART regimen is very frequently used, that means this drug, the clinicians usually prescribe this drug combination. So we assume they are the representative ART regimens. And based on these 56 representative ART regimens, and we use a PCA on this kernel weight matrix, and we choose 39 principal components that explains over 99.9% of variation of the original matrix. So the D star is 39. Okay, so here's the clustering results. The left figure is a true cluster. We have 3 clusters, and the right one is an estimated cluster. So we can see we only have 1 subject here is misclassified, but most of the subjects, they are correctly assigned to their true clusters. And also we evaluate the model in estimating the ART combination effect. So we compare our methods to 2 alternative methods. Here we call our method as DDCRP plus ST, represents the DDCRP prime and the subsaturated kernel method. So the first alternative method we call the normal plus linear. So this alternative method replaces the DDCRP prime with independent conjugate multivariate normal price. So this way we do not take into account the individual's heterogeneity. And also we replace the subsaturated kernel with a linear kernel. So remember, the linear kernel just computes the number of the same drugs used by these individuals. So if you use a linear kernel, then we do not take into account the this kind of like, like if you use similar drug combinations, or if you use different drugs from the same drug classes, you still share certain similarity. Okay, and the second alternative method is DP plus linear. So we replace the DDCRP prime with a division process prime. So it takes into account the heterogeneous population, but it doesn't account for the individual's treatment histories. And also we replace the subsaturated kernel with a linear kernel. And here is the results. So we randomly select 2 individuals. So here the black line is the truth. And of course, for the normal and the linear, here's the green line. Both of them are very far away from the truth because you don't even take into account the heterogeneity. And also for the DP and the linear, and for this case, we can say it's relatively close to truth, and it's comparable. It's comparable to the DDCRP plus the subsaturated kernel, but for individual 2, our methods are significantly perform better compared to these 2 alternative methods. Okay, and by the way, here's the x-axis number of visits. So the first individual has 7 visits, and the second individual has 21 visits. Okay, so now let's move to the real data analysis. So for the West data set, we have about over 3,000 women with HIV. And here we consider all these variables. We consider their clinical site and enrollment wave. And also we consider these social demographic variables, and also all those behavior variables like smoking, alcohol, marijuana, crack cocaine use, and also this clinical like hepatitis C antibody and BMI, hypertension, diabetes. So we consider all these variables in the model. And we included all women who had at least 5 WISE visits with complete data. So because we don't want to consider the women with only maybe 1 or 2 visits, because we're trying to estimate this longitudinal drug combination effect. And also we use the similar way as simulation study. We select the representative ART regimens if a regimen has been used in more than 10 visits. And also we return the principal components that explain over 99.9% variation of the kernel weight matrix. So at the end, we have 628 women, and we have 127 representative ART regimens. And after the PCA, we have 58 principal components left. And also we have 24 ART agents and 5 drug classes. So after the data, we applied our methodology to this data set, and we identified 4 clusters. And the first 2 clusters have very large number of individuals. So the first one have 374 individuals, and second cluster has 233. But the last two classes only have very small number of individuals. So for the following clinical interpretation, we will only focus on the first two big clusters. Okay, so here is a table for the clinical characteristics of these four clusters. So we can see these four clusters have kind of different clinical characteristics. And also we have the table summarize their drug uses information. We have in total 24 drugs. So I want you to pay attention to their this class 3 and 4. So we can see the class 3 and 4, no one used here the integrase inhibitor and also the entry inhibitors. So because the integrase inhibitor and entry inhibitor, they are two relatively new types of the drugs. So we feel like, you know, the class 3 and 4, they might be the patients who visited the clinic a long time ago. They haven't really visited the clinic in the recent years, because recent years, FDA already suggested to use the integrase inhibitor and the EI for treating HIV. Okay, so here is the data summary for the different clusters. And then we also here we show the posterior means and 95% credible intervals for the estimated coefficients in the non-ART effect in our model. So here we plot the effects with respect to age, CD4 count, viral load, and hypertension. So for example, here we have different colors represent different depression items. And we only have class 1 and 2 for the clinical interpretation because they have more individuals compared to class 3 and 4. So for example, we can see for the CD4 count, those have negative coefficients. It's expected, right? Because the higher the CD4 count means this person has better immune function, and then their depression score should be lower. So they have negative relationship. But for the viral load, we can see, so in the class 1, they all cover 0. So that means they are not significantly affect their depression. But however, for the class 2, and some of them, does not overlap with 0 and they are positive. So it's also expected because the viral load means this person's disease situation is not good. And then maybe this person will be more depressed. So we can see the positive relationship here. So all the findings here is in agree with the clinical knowledge. And now let's go to the drug combination effect. So we first plot these first two principal components. Okay, so the first component is positively associated with somatic, negative, and positive in class 2. So because here for class 1, all the credible intervals cover 0, so that means the effect kind of not significant. So, but for the class 2, we found out the principal component 1 is positively associated with this somatic, negative, and positive. And for the principal component 2, they are negatively associated with somatic, negative, and positive in class 1. But for the class 2, they are not significant. So just looking at these first two principal components, we don't really know anything about the drug combination effect, right? So now let's see how to connect the principal components to their exact drug combinations. And here is how we do that. So we've listed the top 5 positively and negatively related to ART regimens for each principal component. So remember the first principal component, they're positively correlated in the class 2, and for the second is negatively related. So now we list the top 5 principal components that's either positively or negatively. And now you can look at these signs together. So for the principal component, if they are positively correlated with the depression, and if these drug combinations are negatively associated with the principal component, and then the positive negative together will be negative, right? And also we know the lower depression score is, and then that means this drug combinations has beneficial effect. So for example, here we can see if here is positive, here negative means these drugs are beneficial, or it's negative here, it's positive here means these drugs are beneficial. So for example, here we can find these 2 NRTIs. is FTC plus CDF, and then 1 NRTI. These are beneficial on depression. And also we can see here, the 2 NRTIs and 2 PRs, they are also beneficial. So these findings are also in agreement with the current clinical knowledge, because also these different types of, these two different drug combinations, they are actually prescribed very often in treating HIV. And also if you look at the sign together here, if it's positive here means they will be positively affect the depression. And we know the high depression score is the worst situation of the mental health. So we know these drugs has harmful effects or the adverse effects on depression. So for example, here I have 2 examples here, and people have already found out through some either clinical trials or some observational study, and they found this PI drug LPV and also NRTI, if they're used in combination with these 2 NRTIs, and then they will have adverse effects on the mental health. Okay, of course here I list several known clinical knowledge, but there are also still many clinical knowledge people haven't really studied. So from our study, people actually can pay attention to these drug combinations with adverse effects and more intent to assign patients the drug combinations in these beneficial categories. Okay. And now let's talk about how this method can be used to facilitate the precision medicine in treating HIV. So currently, the US Department of Health and Human Services, they already provide general guidelines on ART treatments. But however, these guidelines do not take into account any individual heterogeneity or treatment histories. So they just suggest, okay, you can use maybe 2 NRTIs and 1 integrase inhibitor, but they didn't really consider the individual heterogeneity and treatment history. So for illustration, we randomly select an individual from the data set with 7 visits in total. And now let's assume we know this person's 6 visits clinical information like age, BMI, CD4, very low hypertension. And this person started the AZT at the first visit, and then added the LAM at the 2nd and 3rd visits. And then from the 4th to 6th visits, this person used the LAM plus AZT plus SQV. So here is this specific subjects for 6 visits. Okay, so now let's consider 2 hypothetical scenarios. And in the first scenario, we assume this individual kept using the same NRTIs, but changed 1 PI drug from SQV to LPV. And in the second scenario, let's say this individual totally switched to a different drug combination. So they have 2 NRTIs and 1 NRTI. And then we apply our method to this hypothetical individual and predict their 7th visit. Okay, and here we say, assume we have already known their first 6 visits, and we plot their predictive depression scores for different items, and also we have their credible interval. Okay, so from these 2 figures, we can see if the 7th visit use this drug combination, it actually leads to better mental health situation compared to the scenario 1, right? So that means if the clinician has several different options for the treatment regimen they want to assign, and then if you compare their predictive depression scores, and then the clinician should assign this drug combination compared to this drug combination. That's how our method can be used for precision medicine in treating HIV patients. Okay, and we develop an interactive web application. So here is a screenshot. So this web user interface interactively displays predictive depression scores of an individual in response to the user's choice of the clinical characteristics and also their ART medication use. So if you're interested in this, and then you can go to this website and play around here. If you change a person's age, very low, and here we will change the figures. Here the predictive depression scores, and also we will give you the optimal potential drug combinations. Okay, so to conclude, We developed a novel Bayesian nonparametric approach to estimate the combination drug effects of different ART regimens on depressive symptoms. And our method, we take into account the individual's background, is including these clinical characteristics. So the physician can prescribe the combination of ART drugs that is least likely to be associated with depression-related symptoms. Or if they have similar effect on the depression-related symptoms, but the clinician still can choose maybe the one least expensive, right? We can consider the cost of these drugs. And the proposed approach can be applied to study the drug combination effects on other outcomes in HIV. So for example, so here we only consider the mental health, but it's possible we can also study the stress, PTSD, and also the efficacy of these outcomes, and also their outcomes on cognition. So all those things might play some roles when we prescribe the drugs for HIV patients. So currently I'm working with several clinicians who are trying to build certain criteria to not only considering the mental health, but also consider all other potential efficacy outcomes and toxicities, and also other comorbidities to kind of create a feasible tool that they can use in clinical practice to treat the HIV patients. And also the proposed method can be extended to examine the side effects of combination therapies for other diseases beyond HIV. So let me talk about one extension we're working on for the COVID-19. So it's a joint work with another PhD student, Kunbo, and also a clinician, Brian Garibaldi. You might be familiar with this name if you saw the White House briefing about the President Trump's health, because now he's in the clinical team of treating Trump for COVID-19. Okay, so currently COVID-19, for COVID-19, there are many treatments. So for example, like there remdesivir is an antiviral drug, and also tocilizumab is targeted for the people's immune system. So we currently have already studied the drug combination effects of remdesivir plus one steroid called dexamethasone. So that's exactly what Brian prescribed to the President Trump. Okay, so we have already studied these two drug combination effects. But if you think about the medical records for all the patients with COVID-19, so we did a simple survey for the COVID-19 patients at Hopkins hospitals. So we have 5 hospitals across Maryland and also the DC. So we found out the number of treatments per patient actually varies a lot. So the mean number of treatments each patient receives is 145. So you see there are many treatment records. And the maximum treatment records for one patient is even over 1,000. As a minimum is 1. And also over about this 238,000 treatment records, there were over 400 different treatments or drugs, and in 315 subclasses. So you see it's a large dimension of potential drug classes, and these drug classes might be ACE inhibitor or statins or antibiotics or heparins or steroids. So they all target different situations or different symptoms of the COVID-19. Like steroid is for inflammation and the statin is for other symptoms. And in our database, we have 6,470 drug combinations, and also the over 95.6% of the patients have drug switches during the hospitalization. So there are many interesting problems here. We're currently working on the drug combination effects for the remdesivir and the steroid. So steroid have many different types of the drugs. So we're currently using the subcentric kernel to kind of calculate the similarity between different drug classes and estimate their effects on the time to clinical improvement and also time to death. So there's another complexity there, is because here we have the depression score is just a continuous outcome, but there we have survival outcomes. Yeah, so it's ongoing work, and thank you. So questions? So that's all, yeah.
Thank you, Yanxun, and for a very nice seminar. So it's time for questions and answers. So Please feel free to ask your questions and just yeah, just unmute your microphone and maybe also show your video, and just in case. I mean, it's better if we can see you. So please ask your question. We have 5-10 minutes definitely available. Questions from biostatistics specialists?
I have a question. So
Yes.
I really liked the use of the kernel to deal with the combination of treatments. And I apologize if you answered this during the talk and I missed it. But is there any reason not to treat that H function as just some nonparametric function that takes as an input like a vector of binary indicators of which treatments are being administered?
So here, let me go back to the model part. So I mean here for the, sorry.
Totally fine.
Yeah, I clicked too fast. Okay, so you mean that for the drug combinations, right? So if you see here. So further here, first, if you use the binary matrices, if you use a binary vector, so for example, let's say we have over 20 possible drugs, right? So, and then you will have a 20-dimensional binary vector to represent this ZIJ.
Right.
But then the problem is, so first, there are many drug combinations, they have never been used. So think about this, if you have a binary matrix for this 20-dimensional, then you should have 2 to the 20 possible drug combinations. And if you exclude the possible drug combination that never used or they shouldn't be prescribed, still it will be a super large dimension, right? It's almost 500,000 dimension of possible binary vectors. So, but our data only observe about like 1,000 drug combinations. So if you use a binary to represent the ZIJ, then you cannot really estimate the treatment effect for all possible combinations.
I see.
Yeah, and also it's like kind of how you write down the, so for example here, like how you write down the treatment effect. Are you going to assume the treatment effect for ZIJ, it's a sum over the individual drugs? That's also kind of not reasonable here, because you know drug they have interactions, so we cannot really use a simple sum over the potential just drug. So because the drug combination effect is not the simple sum of all the individual drugs.
I see.
Yeah.
That was helpful. Thanks.
More question? Well, so if not, let's thank Yanxun again, and for really great seminar. And thank you all for participating in this seminar. Without audience, and no seminar can be successful. So I hope to see you again in about a month's time for our next seminar. You'll get notice. Today we had some mishap, and I apologize for that. So because ISBA's system was not working properly, so they couldn't send a reminder email, and actually the link was never sent. So that's why we had a fewer participation this time, but hopefully this will not happen again. So I mean, but we really very grateful. In spite of that, you guys all joined. And thank you. Have a great day and have and be safe.
Yeah. Thank you, everyone.
Take care.
Bye.